Vijay. You can go live now.
Hello, good morning, everyone. I'm Vijay Thorat, working in the marketing team of Hetero Healthcare Limited of HIV and Rheumatology Division. I welcome everyone for this wonderful talk on PrEP and PEP based off our HIV. And I'm sure you will not regret of investing your 2 hours of this Sunday morning. This is a very interesting talk on HIV and AIDS. And when you talk about HIV and AIDS, I would like to tell you about the heteros who have played a significant role in managing this HIV/AIDS crisis by manufacturing one of the first APIs in India and making it affordable for the Indian patients too. Everybody must have heard about hetero during the COVID pandemic. Similarly, the company has worked rigorously throughout various pandemic till now. One of that is HIV too. When you talk about HIV, India as a country has made tremendous work in controlling this pandemic. And if you see it in current statistics, it's now 2.4 million cases which we are having. But the concern is still we have more than 66,000 cases coming annually. And the most major concern in that too is the younger population are amongst the affected ones, and people with risky behavior pattern. And to talk about this, how we can really prevent these new infections, and what is this PrEP and PEP, we have organized this webinar, which is one of the regular events in academic platforms which we conduct in HIV and AIDS. And to take you about through this webinar for next 2 hours. We have our medical team, medical services manager, Ms. Hetal. She'll be taking across this event and handling the question answer sessions. And we know our speaker, and to introduce our speaker, I'll request Hetal to take on from here.
Very good morning, everyone. My name is Hetal Gohil, and I'm working in the Medical Services Department of Hetero Healthcare. On the behalf of Hetero Healthcare, I would like to welcome you all to this webinar on HIV prevention strategies, as we say, that is PrEP and PEP. Before we proceed with our scientific agenda, as Mr. Vijay Thorat has already explained currently, I would like to take this opportunity to brief on Hetero Healthcare, which is among the largest producers of APIs in the world and has been a strong partner in HIV experts across the globe. At Hetero, our every action seeks to inspire human belief in accessibility and affordability of life-saving medicines across the world. We mark more than 25 years of our journey in HIV management and prevention, and catering to 40% of existing global demand for antiretroviral APIs and finished dosage form. This was possible only due to strong R&D team and state-of-art manufacturing technologies or the facilities that we have that have ensured the seamless supplies of this medicine. This journey wouldn't have been so fruitful without your support and blessings. As we know that around 1.3 million individuals worldwide acquire HIV at the end of 2022, which has been documented by WHO, marking a 38% decline in new HIV cases since 2010 and around 59% since the peak in 1995. Over the decades, the life expectancy of people living with HIV has increased due to improved efficacy of highly active antiretroviral therapy. The Centers for Disease Control and Prevention has estimated that around 50% of people living with HIV are older than almost 50 years. The goal is to prioritize HIV management and prevention, along with improving quality of life with people living with HIV. HIV prevention efforts have been continued to evolve since the beginning of HIV pandemic. Although CDC reports that the rates of new infections it's not rising actually, the prevention efforts are still essential to combat the HIV pandemic in certain high-risk population, such as male-to-male sexual contact, transgender individual, or people with multiple partners, etc. Okay. So, more than 40 years of global experience in managing HIV has demonstrated that a patient centric approach is very much required for the optimal prevention of HIV. The cornerstone of any HIV prevention strategy is to offer antiretrovirals to all at risk individuals, either as pre exposure prophylaxis or post exposure prophylaxis. To discuss this further in detail, I would like to invite one of the eminent Dr. Ishwar Gilada, to educate us on this topic of let's talk about PrEP and PEP. Dr. Gilada is the first person to raise alarm against AIDS in India in the year 1985, and following year, he started India's first AIDS clinic. Dr. Gilada is a globally acclaimed HIV expert, credited with bringing India on the AIDS control map of the world. He is HIV STD consultant at Unison Medicare and Research Center, Mumbai. He is also President Emeritus of AIDS Society of India and elected as Governing Council member of International AIDS Society. He is also Secretary General of People's Health Organization of India and of Organized Medicine Academic Guild, which is a national federal body representing 20 professionals. He has also addressed more than 4,000 meetings and training programs in India and several high risk HIV African countries. He has also presented more than 300 scientific papers. He is actively involved in prevention, control, and management of HIV since 1985. With this, I would like to hand over the session to Dr. Gilada. Over to you, sir. I thank you everyone for joining us today. Thank you all. Over to you, sir.
Thank you very much, Chetan. When we talk about HIV/AIDS or STD or any disease, and we talk prevention, control, and management. For medical community, prevention control is separate and management is separate. When I started my work with the red light area, when I started working on the STD prevention, and when I started doing a survey amongst the medical specialists, particularly STD specialists, and asking them, should we have some kind of legal system to control STDs, or should we have some kind of projects to control STDs? And my colleagues at my department in STD in JJ Hospital, they opposed me. And a lot of STD specialists said, what nonsense you are talking. By controlling STD, you are axing your own feet. If there are all STDs are controlled, then how do you practice STD? So basically, most medical community, they look at tubular vision. In the specialty you work, you are only doing clinical management. And therefore, on one hand, you keep increasing the infection, and on the other hand, you keep managing. But I realize that that is not the real way. We have been taught in prevention, preventive and social medicine, 5 different levels of prevention. And primary prevention, secondary prevention, tertiary preventions are very important. Now, that's the reason that when we talk about any STD, any including HIV, we must focus very much on prevention. And that's how the National AIDS Control Organization started. The National AIDS Control Program was started almost in 1986, but NACO was started in 1992. And the primary goal was prevention. And then testing, etc., came in. But what happens when the newer things are added, the older things are forgotten. And therefore, now currently we are focusing on HIV management, viral load, and a lot of other things for management. And we are forgetting prevention. And by forgetting prevention, we started seeing the spurt of newer STDs and newer HIV cases in last couple of years, particularly for last 5 years. So the graph of India, which was going up, going down, started going up. Let me share my slides and go on that. So when we talk about okay, so when do you see my first slide? Where is a man is confused, sitting and having a lot of thoughts: HIV, AIDS, condom, suicide, homosexuality, wife, death, masturbation, birth control, relationship. So whenever a person is either infected or thought to be infected, goes into this kind of scaremongering internally, and sometimes get phobic. So counseling plays very important role, both at the community level and at individual level. This is the disease triangle we are talking about. You describe any disease. At the center, there is a disease, but what decide whether it will be disease or not? The pathogen, which is the organism. Organism can be virus, fungus, bacteria, parasite. Environment, whether the environment is supported to the host or supported to the pathogen. And then the host, what is the constitution of host? What is the immunity level of the host? What are the factors which are genetic factors in host? So all these three will decide whether there will be disease or the person can be saved. In my presentation, I'm going to cover PrEP and PEP, but broadly also talk about gaps in prevention, understanding sexuality, exposure, risk patterns, definitions and simplification, non-drug PrEP, because when we talk PrEP, we only medicine comes in our mind, but there are a lot of non-medicinal PrEP. PrEP and in the PrEP trials. In PEP, what is the classification of PEP? Post-exposure prophylaxis. What is the evidence, when and what, and monitoring. So by this way, I will try to cover. I thank Hitro for giving me this opportunity. Most of the times when you are speaking at a medical fora, you get a limited time, 15 minutes, 20 minutes, 25 minutes, maximum half an hour. And you need to concise all your information in that particular time limit. But Hitro is generous in giving me more time so that I can explain to you in greater detail, because I don't want to do a kind of a just hit and run approach. So when we talk about current pandemic, particularly HIV, we are dealing with almost 40 million HIV infections right now. There are 40 million people living with HIV infection. And every year we add 1.3 million. And every year, 500,000 and more than 500,000 people die of HIV-related illness. To tell you frankly, with the current advent of HIV management, there is no need of anybody dying of HIV. With good and current management, what I can guarantee my HIV positive patient, four things. Number one, you don't have to die of HIV. So you live a full life as much as is guaranteed by life expectancy at birth in a particular country. In India, it is 71 years for male, 73 for female. So even if you are diagnosed HIV at 25, you can still live up to 71 and 73. Number two, you don't have to be sick with HIV and don't have to be hospitalized for HIV-related illness. You can be hospitalized for heart problem, knee problem, accident, cancer, etc., but not for HIV. Number three, you don't have to transmit HIV to your wife or partner or any sexual intercourse once you are treated for a couple of months and you become undetectable. Undetectable is untransmittable. And fourth and most important, you don't have to compromise your life, personal life, sexual life, or your financial life or professional life. Nothing needs to be compromised. Huh? So when we talk about HIV in India, you can see the graph from 2003 till 2020. It kept on going down, down, down. For almost 7 to 8 years, we maintained our figures at 2.5 to 2.3 million. And suddenly in 2022, we see 2.5 million. Maybe there is an effect of COVID and people got infected in COVID. They could not go for prevention. They could not go for testing. They kept on either getting infected or transmitting infection. But currently we see an increase in COVID, in HIV. 2023 figures we don't have, but probably it is much higher than 2.5. So when we look at age, when we talk about sexually active age, and that is mainly between 20 to 40, 20 to 50. It doesn't mean that people at 50, 60, 70, they do not do sex. But the number of sexual act, number of sexual activity, number of initiation, they are much in the younger age. And therefore, our focus is at young age. And half of the population is below 25. So when you talk about 1990 gap, in UNAIDS there was a target of 90% people with HIV infection should know their status. 90% of the people who know their status should be on ART, antiretroviral therapy, and 90% of those which are on ART should be virally suppressed. That means they should be undetectable. However, there are gaps, and the gaps are basically there are people who are not virally suppressed, they can keep on passing infection, and our prevention combination is not properly working, and therefore we need to work on those issues. So when you look at the target initially was 90, 90, 90. When they realized that a lot of countries could not meet that target, they made another fast tracking target, which is 95, 95, 95. So same, rather than 90, 95% people should know their HIV status. 95% people should be, those who know HIV status should be on ART, and 95% should be virally suppressed. But when you look at the gap, there are gaps where people are discriminated. So then they made another target that less than 10% of the countries have punitive laws and policies. Less than 10% experience stigma and discrimination. And less than 10% should have experienced gender equality and violence. So currently we see discrimination of HIV positive people is at all levels, including medical establishment, including for deliveries, surgeries, dialysis, any kind of procedure, and either HIV positive person is charged double or 1.5 times more, or they get into the problem where nothing is done, and they kept shifting patient from one to another place. So when we look at combination of HIV prevention, there are a lot of issues, and there could be vaccine, but currently there is no HIV vaccine, and that research is going on for last 45 years. Till today, there have been more than 99 candidate vaccines, not one is successful. PEP, post-exposure prophylaxis, oral PrEP, pre-exposure prophylaxis, behavioral positive prevention, treatment for prevention, it's called TASP. If there's a couple, if one is positive, other is negative, you treat the positive person, the negative person will remain negative. That is called treatment as prevention. Microbicides for women, male circumcision, which I'll explain to you, treating those people, treating STDs, behavioral change, behavioral modification, male condom and female condom. So when we talk about prevention of HIV/AIDS, this is the ABC model is much more famous anywhere in the world. There's abstain from sex, be faithful, and use condom. So basically, we do not advocate everybody will abstain, and even if we advocate, it may not be followed. So be faithful. Choose your partner, be faithful. But the faith is very difficult to get, and therefore use condom. Even condom usage is not guaranteed 100%. So 70 to 80% risk reduction of HIV transmission can be achieved through condom promotion by way of different observational studies. Circumcision in male reduces 60% of HIV transmission from women to men. And there are drugs for HIV prevention, prevention from mother to child transmission. Earlier with one drug, AZT 67.5%, now 100%. Post-exposure prophylaxis, earlier it was 80% risk reduction, now nearly 100% risk reduction with 2 or 3 drug combination rather than one drug earlier. The treatment of HIV infected individual, earlier 93% of risk reduction was there of HIV transmission, now 100%. U is equal to U, undetectable is untransmittable, untransmittable is 0. And pre-exposure prophylaxis, non-drug PrEP and oral PrEP. In HIV prevention, there are challenges because there is an inadequate sex education bundled with risk-taking tendencies, low rates of testing. HIV self-test is not approved in India. You can go on a different marketing platform, buy a kit, but that is a double standard, where on one hand, it is not in program, it is not licensed, but on the other hand, it is available. Low rates of condom use. There are a lot of myths and misconceptions related to condom, and that can be a separate topic by itself, how and what are the myths and misconceptions. Substance use and policies, again in dilemma. We do not know whether to ask people to provide syringes and needles rather than stopping the drug addiction. So this dilemma continues, and therefore we as a doctor take a lesser of the two evil. If we cannot stop the drug use, if we cannot stop an individual from taking drug, make them at least not share and provide them clean needles. High rates of STIs are there, as fresh part has seen, with stigma around STIs. The moment, like for example, after the sex you get pregnancy, and that is called good news, particularly in a married couple. So good news. But with the same sex, you it can get STD, but that is bad news. So we have ourselves created stigma and aura around that kind of word. There's a lot of homophobia and transphobia. Feeling of isolation and minority stress is there once you are in a particular minority group, and you always think that you are not in part of mainstream. So there are guiding principles of prevention success: a location population approach addressing the heterogeneity of the epidemic, a people-centered approach, partnership between government and communities, and public-private partnership, which is needed and required. Community-based organizations can deliver quality HIV prevention services, and CBOs can also advocate for legal and policy reform. And that's how we have today HIV/AIDS Act 2017, and that is an entire 3.5 decades of pressure on government, and that was delivered as this act. So in sexual health, there's a male, female, the animals involved, determination involved, plants involved, chromosomes involved, a lot of things are involved. Now, when we talk about sex education, this was in 1996 in Time magazine, the front page news item on sex education. And again, what it was said today in room number 301, there will be a talk on birds and bees. So we camouflage the sex education talking about birds and bees rather than human beings. So in India, we have double standards and carpet culture. Above the carpet, very clean, below the carpet, fine dust. We have sex in abundance, otherwise we cannot be number one in population. But we do not want to talk about it. And that we not only top in population, but also top in STIs. So if we look at the homophobic climate index of 2016, there are some countries where they are well accepted. There are some countries they are not accepted at all. There are some countries in between. So India is in between, and we still have that kind of homophobic climate despite repeal of the Act 377. So there is heterosexuality, homosexuality, bisexuality, and all these sexualities are involved, and therefore we need to look at LGBTQIA also. Now, how the things were almost 10, 15, 20 years back, and how are the things today? The awareness campaigns were at peak during 1995 to 2005. And there used to be huge response, like for our exhibitions at Churchagate and VT, we used to get 100,000 people attending the exhibition every day. We used to have AIDS march, we used to involve people, do street plays, do mobile clinics, but all those campaigns were around up to 2005. I used to go with the garland of condom in the red light area. Even our mobile clinic used to carry AIDS messages. And over the years, we could sensitize people, we could involve people from the film industry like Mr. Sunil Dutt. We could involve a lot of influential people, create that kind of awareness. And for every awareness, there was huge response. But what has happened? The COVID effect. Those awareness campaigns were up till 2005. Those who were born during that period or a couple of years before, when they are 4 or 5 years at that time, they are now grown up, they are now 20, 25, and they have neither experienced nor benefited from this kind of awareness campaign. So a lot of times they have heard, they have known, but they have not been exposed to campaign, particularly how to take precautions and how to manage those kind of pressures. So we need to have innovation in awareness campaign with social media, social networking, for a mobile apps. We have to invent Tinder, Grinder apps, which I will explain to you. We have to catch people at young age. We need to have college orientation program. Even medical student and postgraduate student in medical colleges, they are not exposed to proper sex education. Non-formal youth. So when we talk about marginalized communities, there's a traditional forte for STIs, but now it's fast changing. We used to earlier think sex workers, male and female, hijras and eunuchs, I done my postdoctoral dissertation on the HERA community in which was between 1984 to 87. And that time, the term itself was that they are born like that, and it was never described that they can be transsexual, transvestite, and they can be eunuchs. So we did that kind of research. MSM community, LGBTQI, professional blood donors and organ donors, injection drug users, and truckers. And these were marginalized communities, these were stigmatized communities, but somehow those communities are mainstream. So what is the shift today? We see newer infection, STIs as well as HIV in IITians, IIM, IT professionals, real estate, politicians, journalists, travel people like pilots and crews. So this is endless, and they do not think they are taking any risk because they don't think that they've gone to sex worker. They don't think that they have taken any risk. They had sex with colleague. So when we talk about factors affecting or influencing sexuality, they could be biological, congenital, age, sickness, injury, pain, fatigue. They can be environmental, like lifestyle, proper premises for sex. If you do not get privacy, then you try to do whatever you get, you compromise. Privacy issue is very important in sexual activity. Psychological, this can be stress and strain, bitter experience in the past, half-baked knowledge, disturbed family, undue expectation, death and illness of partner, and pregnancy of a partner. Hormone and genetics, medicines, there are alpha blockers, amphetamines, anticonvulsants, diuretic, they influence sexuality negatively. Marijuana, alcohol, smoking, hash, weed, LSD, recreational drugs, they influence sexuality. And that is towards the multiple sex partner history. So basically, when we talk about sexual history, how to elicit, age at first sexual exposure, what is experimental, was it experimental, was it under peer pressure, was it under influence of alcohol or drug or anything, was it because of marriage, was it because of threat and blackmailing, was it a sex abuse? We started actively asking this question, and we find at least 4 to 5% people have been sex abused, and therefore they were inducted into sexual activity. Number of exposures, whether single or multiple, whether they are live-in or bisexuality, whether there is number of sex partners in a day, sometimes in several days. I had one person who had 12 sexual partners in one night. Orgies, partner exchange, date of last sexual exposure with wife, regular partner, and outside. Sex of partner, sex of partners. What is the sex of partner? History of male to male, male to female. In male to male is whether top, bottom, or versatile. Type of intercourse: oral, vaginal, anal, protected and unprotected. Non-penetrative sex, which is body to body massage, mutual masturbation, mammary sex, rubbing, cudding, kissing, deep kissing, sex bites, and the list can be endless. Vibrators, e-sex, and ever had sex with non-humans. And I have such patients who had sex with non-humans. Which STIs are currently increasing apart from HIV? Herpes simplex 1 and 2, HPV, human papilloma virus, and we have seen from a Tata Cancer Hospital study in Mumbai, more than 50% of oropharyngeal cancers are because of HPV. So there is something called a 69 position, where orogenital sex both the partners are having and pick up infection from the other infected partner. Syphilis, gonorrhea, chlamydia, and donovanosis. So what is exposure basically? Broadly, when we talk in medical practice, exposure is the exposure to any infection. So like in TB specialist will say exposure to TB. COVID will say exposure to COVID. In STD and HIV practice, we talk exposure means exposure to sex or sexual activity. It depends on type of sex acts, changing pattern of sexuality. However, when we talk about today's session, it is exposure to scientific knowledge. So expose yourself to this session to prevent exposure to the infection. When we talk about definition of exposure, the contact with a potentially infectious blood, tissue, or body fluids. The percutaneous injury, percutaneous means through skin. Contact of mucous membrane or non-intact skin. What is the infectious material? From an infected person, blood is infectious, semen or vaginal secretion. Other body fluids contaminated with visible blood. Potentially infectious are cerebrospinal fluid, that is a brain fluid, and that you do not, as a person, individual, do not come in contact. Synovial fluid, pleural, peritoneal, pericardial, and amniotic fluid. So these are potentially infectious. And what are non-infectious? Feces, nasal secretion, saliva, sputum, sweat, tears, urine, gastric secretion, and or vomitus. So basically, if sweat was our sweat, pasina, अगर infectious होता, so everybody in Mumbai could have been infected when you are traveling local train and buses. So when we talk about risk of seroconversion after needle stick injury in medical professional, so if you get a needle stick injury, if the person is infected with HIV, hepatitis B, hepatitis C, and say syphilis, your chance to pick up HIV from one single needle stick injury is 0.3%. Almost 10 times more than that is hepatitis C, and almost 100 times more than HIV is hepatitis B. So the chances of transmission of hepatitis B are the highest, HCV are the in middle, and HIV is the lowest. Relative risk of transmission after needle stick injury, if it is a deep injury, 16.1%. Visible blood on device, 5.2%. Needle placed directly in your artery or vein, like injection drug users use, 5.1%. Terminal illness in a resource patient, 6.4%. So a person is terminally ill, virus load is not controlled, never treated with HIV. But post-exposure, use of AZT, 0.2%. So if somebody has been on AZT, then your chances are low. So in conclusion, it is not very easy. But relative risk of transmission, if we talk about percutaneous, 0.3%, 3 in 1,000. Mucous membrane, 0.09%. So that is, you talk about oral kissing, deep oral kissing. Non-intact skin exposure, 0.09%. And intact skin is 0%. So sometimes a lot of phobic people come and they say, I touch semen, I touch vaginal secretion, I touch condom. You do not get HIV like that. So we need to have a categories of exposure. What is a mild exposure? What is a moderate exposure? What is a severe exposure? And accordingly, we need to decide whether PrEP, PEP, etc., what is required. So when you talk about risk of transmission from a HIV infected individual, not on ART, type of sexual exposure, an estimated or range of estimated median range, risk per exposure. Receptive anal intercourse, which is 1.11%. So the person who is at bottom is receiving anal sex is very high chance per sex. But insertive anal intercourse is much lower. So it decides on how much area of your body is involved in that activity. So if you calculate the area of anal canal and rectum canal is involved, and the area of your penile area is involved, so that other area is much bigger. Same way, receptive vaginal intercourse is 0.1%, but insertive vaginal intercourse is less than that, almost 10% of that. Receptive oral sex, fellatio, is 0.2%. Insertive oral sex is almost 0%. And blood transfusion is 90 to 100%. Needle stick injury, 0.3%, which I already said. And sharing injecting equipment is double than that. So when we talk about what has happened in recent times, the increase in sexual act and casual sex is very high. And why? They are most popular dating apps in India: Tinder, OkCupid, Happen, Bumble, Truly Madly, Woo, Grinder. Currently, Grinder has gone up, I think, close to Tinder. Coffee with Megal, Hinge, Ezel. So when I am giving you this name, it doesn't mean that if you are not indulged in sexual activity, just go to any app and start engaging from today. My job is to prevent you from infection and not propagate sexual activity which you have not been performing. So understanding prophylaxis or prevention is the process of guarding against development of a specific infection or a condition by an action or treatment that affects pathogenesis. Pre-exposure prophylaxis is a preventive step or treatment before exposing to the stimulus or pathogen. So, and levels of prevention, as I was telling you, the primary level is avoid development of a disease and remove risk factor. So if there is a disease onset already started, Then you go to the secondary prevention, that is called early detection and treatment and prevent progression. And if you have missed that bus also, then it goes to clinical progression or clinical diagnosis. At that time, you can only have tertiary prevention, that is reduce complications of the established disease. In HIV infection, PrEP and PEP, how it is simplified? If HIV infection is considered arrest, because people understand what is arrest, then PrEP is like an anticipatory bail, and PEP is like a bail after a cognizable offense to avoid that arrest can be avoided. Not all PrEP and PEP can prevent arrest. So we need to understand their limitations and the best results. In simplified another language, if there's a raining outside and you have to avoid getting wet, either you sit at home or you go prepared outside with either a raincoat or umbrella. Even best quality raincoat or umbrella can be broken, and therefore those things are safer. They are not always safe. So therefore we understand the limitations of PrEP and PEP or condom use as a safer sex. When we talk about PrEP versus PEP, sometimes the drug can be same. PrEP stands for pre-exposure prophylaxis. This PEP stands for post-exposure prophylaxis. PrEP means taking antiretroviral drug before being potentially exposed to HIV to prevent becoming infected. And PEP means taking ART after being potentially exposed to HIV to prevent becoming infected. So this is before, this is after. So when we talk about pre-exposure prophylaxis, I will first harp on the non-drug PrEP, and they are non-pharmacological or non-drug preventive strategies. They can be primary prevention. Currently, there is no vaccine or cure for HIV/AIDS. So primary prevention is not available. The only known method of prevention are avoiding exposure to the infected person, and that is abstinence, monogamy, partner selection, partner reduction, and non-penetrative sex. Avoid alcohol or drug use, needle syringe exchange program and methadone substitution instead of drug, barrier protection where male and female condom can be used, but that has to be regular use. STIs, avoid sex with the partners with symptomatic of STIs. Regular STI screening, self and the partner. Voluntary medical male circumcision, VMCC, treatment as prevention, and then lastly comes oral PrEP. So when we talk about having no non-pharmacological, the best thing come to my mind is a treatise which is Sage Vasayana, devised 1800 years back, and it's Kama Sutra. And we devised a slogan, many postures with one partner better than one with many partners. And this became one of the most popular slogans during 1990 to 93, even published in the WHO booklet as one of the most innovative campaigns. Then we started a strategy of mobile clinic, where the mobile clinic is parked, public announcement is made, mobile exhibition is there, group meetings are going on, question answer session is there, HIV testing is done in the van, and results are given. And what was the approach? Be good. If you cannot be good, be careful. In any case, be informed. Then, when initially we talked only about this street brothel prostitution, at that time, people were not worried about getting infection from call girls or bar girls or high-class sex workers, where they thought if they paid more money, then that girl is safer. And therefore, we alerted the government that even sexual activity at these places also is risky, and we should have intervention at these strategies at these places also. We scaled up the combination prevention, and that can increase consistent use of a condom and reduce HIV infection among female sex workers. In Mumbai itself, at that time, we used to distribute close to 1 million condom per month. So condom distribution program, and going with the garland of condom, sensitizing community, doing a program just outside the van where people will gather, and teaching the sex workers how to use condom, how to put on condom, because most of the clients were not educated. And therefore, UNAIDS best practices included our Saheli project as one of the best peer education models globally. Sometimes translating treatment as prevention in community is difficult. For example, when a couple comes, one is positive, one is negative, and we started treatment in a positive person, but till that person is tested next time and found undetectable, still sex can happen. And therefore, what is ideal is not always practical. And there is no silver bullet, and we cannot depend on only 95, 95, 95 to treat ourselves out of the epidemic. Then the combination prevention is a proven impact. Economic empowerment of women and girls and cash transfers to prevent them getting into some kind of allurement. Secondly, education for girls, so that once they are educated, then they will not indulge in indiscriminate sexual activity. There was one program in South Africa. They said preventing HIV in girls through bicycles. How? Because I couldn't understand initially. They said that if the girls are provided bicycle to come into the school, they don't have to depend on other males to just give a lift, and on the way they can have sex with that girl. So they provided all young adolescent girls with the free bicycle from government so that they can go on their own to the schools. Community empowerment program, which are also there for the sex workers in India, and harm reduction policies. Combination prevention taken daily. Oral PrEP is an additional prevention option. It should be used in combination with the other prevention such as condom. PEP, healthy lifestyle, treatment for other STIs, male circumcision, and TASP. ART for partners. Remember, counseling should highlight that oral PrEP is ideally to be used only with condom. But a lot of gaps still persist, and we have look at sex workers, gay men, transgender people, and people who inject drugs. Everywhere there are a lot of gaps, and therefore currently what we see, almost 70% of the HIV infections are in these communities, which are called key populations. So 5 prevention pillars are there, decided by United Nations General Assembly, UNGA. And I'm going to show you each pillar, 1 to 5. So pillar 1 is basically adolescent girls and young women, AGYW, and their male partners, what is needed. So inclusion laws and policies, defined packages, what are to be given to them, adolescent-friendly services, address structural issues, improve data, and age disaggregation. Not all adolescents are the same, so we sometimes may have to make a tailored approaches. Pillar 2 is a key population, and that is a comprehensive service package. So key population, as I shown you, they require health intervention and structural intervention. And if you do combinedly properly, involving the communities, have a peer education model, then things will improve in that particular key population communities. Pillar 3 is condom and lubricants, and which are well explained everywhere, but you need to understand the varieties of condom. Powdered ones are phased out, colored, flavors, with naloxone 9, with sizes, with thickness, and female condom. And in condom, it is not only just top condom people will use it. We need to have leadership and coordination. We need to have supply and community security. This should be always available. There used to be a shortage of condom during our peak times when we had a campaign in the red light area. Demand, access and utilization, and support. So support system is required everywhere. This is a female condom. This is a male condom with a disposal pouch, because one difficulty we came across was people were using indiscriminately and putting it somewhere. Once we were doing a program in a SNDT Women's College, and after the program was over, we were called for a cup of tea in the director's chamber. And the director said, Dr. Gilada, we are going to stop giving our ground for Navratri. I said, what happened? Well, sir, at the end of Navratri, there were so many condoms lying on the ground, and we didn't want to do that, so we stopped giving. I said, madam, at least we know now that people were having sex earlier and now also. But by seeing condom, you know that people are using protection. So that is a better sign. So we should have some disposable system. And therefore, now there has been a device condom with a disposal pouch. Condoms are effective, cost effective, but condom supply and commodity security has to be there. demand, access, utilization, and disposable, monitoring, tracking, and evaluation. Impact of condom usage has been seen where if there is a lot of like all interventions scale up 2025 target, then the infection can go down to around 200,000, 400,000. And if it's only condom scale up, it will be in between. So it will be around 25-30% reduction of what we are getting today. But if it's a constant 2019 condom coverage is there for all intervention, the graph was little over. So basically, condom scale up is required, but apart from that, you need to have a lot of prevention approaches. Pillar 5 is voluntary medical male circumcision. This is not popular in Asia, but in Africa, there are several countries where they get circumcised to prevent HIV infection. 60% reduction can be achieved in males just by circumcision. In India, if we talk about that, it will become a religious matter. And therefore, we do not progress in that scientific field, and we just look at circumcision as only religious symbol. In 15 priority countries in Africa, particularly if you look at how from 2008 or 9, it has gone up and up. And in 2020, because of the COVID pandemic, it was little lower. So that scale up has been seen everywhere, and the cumulative number of infections have gone down in the countries where they have this voluntary medical male circumcision. So as I told you, it is not popular in Asia and the Pacific. Pillar 5 is PrEP. PEP, that is post-exposure prophylaxis for sexual exposure and other prevention strategies. So when we understand what is oral PrEP and what is injectable PrEP, oral PrEP is not very expensive. It is below 2,000 per month. Condoms cannot be replaced. STD diagnosis and treatment is crucial. HPV and HBV, hepatitis B vaccination, are PrEP for HPV and HBV infection. Physician should be astute in diagnosis and management of HIV infection or acute HIV infection. Injectable PrEP license in India by Medicine Patent Pool, but not yet available publicly. And I think Hetero is one of the recipients of MPP license, but the injectable PrEP is not available in India. So who are the candidates for PrEP? Those who have partners of HIV positive. So if your partner is positive, you should take PrEP till the partner is undetectable is untransmittable. Or if you engage in sexual activity within a high prevalence area or social network and one or more of the following, which is diagnosis of STI, use of illicit drugs, inconsistent or no condom use, partners of unknown HIV status, incarceration in jails and remand homes. There are a lot of infections are happening under pressure, and exchange of sex for commodities. So, and that is definitely a sex work. Effectiveness of PrEP improves with adherence. So there are different studies which are there, and they proved that only if you have adherent, only if you are on daily PrEP, then it will work. In NACO treatment resource group, there has been discussion on PrEP, and on 8th of September 2020, it was decided to launch PrEP, but it is not yet in program. And tenofovir and emtricitabine has been long approved by DCGI for PrEP, but they are still not in program. Sexual transmission of HIV at genital mucosal surface. So when at mucosal surface, which is little bit much thinner, with a single cell columnar epithelium rather than stratified squamous epithelium and skin, the chances of infections are higher, and therefore all these mucocutaneous junction areas, they are vulnerable for transmission of infection. And then PrEP blocks those areas where HIV can get and attach, particularly tenofovir and also to some extent emtricitabine. So when you look at the different clinical trials of HIV prevention options, they have found that Proud, Hypergay, and the partners with PrEP, they were successful, and others were not having very good results. And therefore, we need to look at those strategies. So there are 75% reduction in serodiscordant heterosexual couple, 42% only in HyperX trial, and there are good results in other two trials. I don't want to take you in the trial per se, but I'm just trying to tell you that tenofovir plus emtricitabine, TDF alone can also be used, but TDF alone is not very popular. So only best PrEP which is approved is tenofovir with emtricitabine, and that can be taken as a single tablet per day. Once daily, only currently recommended as a PrEP. Novel investigational strategies may follow PrEP users, and that is on-demand PrEP. On-demand PrEP is very complex, and which I'll explain to you in question answer session. TAF and FTC is also approved, but to some population, not all. For female, it is not useful because TAF requires a lot of time to reach the vaginal area. Long-acting agents, broadly neutralizing antibodies, and vaginal rings. Certain at-risk population may require specifically tailored PrEP intervention. And PrEP initiation by country. There are some countries where PrEP has been almost all those communities which are vulnerable, they have been taking. Even poorest of the poor countries in Africa. And in our region, it is very popular in Thailand, Taiwan, Cambodia, and Vietnam. But in India, it is very, very minusculely used. So when we talk about different prevention strategies of 50 years timeline, so many things have changed. Initially, it was only behavioral change, 100% condom usage in Thailand, no condom, no sex campaign in our Saheli project area. But thereafter, male-female condoms came in, post-exposure prophylaxis came in, male circumcision, treatments as prevention, oral PrEP. So these are all keep on adding. And then there are so many other things in the pipeline for the next 7-8 years. Dapivirine is also a recent development in HIV prophylaxis, and it is still in a kind of investigational stage and is not popularized yet. There are also broadly neutralizing antibodies. There can be biannual injection of HIV as a PrEP, which only take twice a year injection. And then from bench to bedside, whatever research are done in lab and how they get bedside or to the people, that whole algorithm is explained here. Now coming to post-exposure prophylaxis, once you are exposed. So it is in HIV has given us a lot of popular terms, but they are not new terms. We were not understanding. For example, we were working in the red light area. That term got targeted intervention. We never knew what was target. We carrying on. Similarly, if you look at to prevent leptospirosis after red, we provide 2 tablets of doxycycline. To prevent rabies, we provide vaccine. To prevent tuberculosis, we provide IPT or preventive tuberculosis course. Hepatitis B, rapid immunization or immunoglobulin. So that is also post-exposure prophylaxis. Syphilis, we provide penetrura or long-acting penicillin injection. Gonorrhea, chlamydia, and now the IAAS, International AIDS Society, and WHO has come to doxypep. So after the exposure, you can take 2 tablets of 100 milligram of doxycycline that will prevent syphilis, gonorrhea, and chlamydia together in only 1 dose. So these kind of terminologies have come, and we should make it more popular. Now in PEP, there are 2 different PEP. One is occupational PEP. Occupational is in medical community, doctors, nurses, technicians who are working, ward boys, IAs. So they get needle stick injury. Needle stick injury can be usually accidental. Sometimes needle is lying somewhere. Sometimes you're talking on mobile like this and then drawing blood. So you can get those accidental injuries. Or mucosal exposure where you are doing some procedure, suddenly amniotic fluid comes or suddenly some pus comes and it comes on your body. So we need to have that kind of protection. If that is not done and if you are exposed, then we need to provide you PEP. So for example, when you look at capping the needle, this way of capping is wrong. How you should cap is you keep the cap against a hard surface and then you insert the needle so that anything happens, the needle will go in wall or in the hard surface only, not it will go into your body. Non-occupational exposures are basically called post-exposure prophylaxis after sexual exposure. That is because of condom breakage. Condom breakage can be at the tip, in the middle, or the shaft, or rim. Condom breakage at rim doesn't cause any much of risk. At shaft, it depends on whether it is closer to the tip or whether closer to the ring. And tip is definitely a risky activity. Condomless sex with HIV infected person, sexual assault. For 10 years, 15 years, we have been fighting that when your victims of sexual assault come, we look at from all only forensic angle, crime angle, police angle, Panchanama angle, but we never looked at that victim of sexual assault can get HIV or STDs. But at least now that has been approved and sexual assault victims are provided post-exposure prophylaxis. I'm glad that NACO has included this in their program. Sharing injections, non-occupational percutaneous injuries, where it can happen. Non-occupational means you are providing a home care among your family and somebody is infected and you got percutaneous injury. So that can also happen. So there is a study which was done in Sao Paulo and where sexual assault less than 72 hours were given PEP, more than 72 hours were not given PEP, so they were used as a control group. What they found, seroconversion was 0 in 182 PEP group and 4 in 145, which was a control group. That means there is a definite prevention of HIV in those people who are given PEP. So in PEP, we look at 4 different parts: risk of HIV acquisition, timing, follow-up testing and monitoring, and adherence and risk reduction. So when we talk about risk of HIV acquisition, so let us see HIV status and risk assessment of expose and the source. So in risk, exposure is considered high risk if there is a condomless anal or vaginal intercourse. Percutaneous exposure to blood. Start PEP if the source is HIV infected or source is at high risk of being HIV infected and if there is a victim of sexual assault. If unknown, proactive step and find out. If known, assess the risk. If negative, no PEP required. Unless acute HIV infection may be suspected, high risk population, sex workers, MSM, and injection drug users. If positive, look at viral load, other STI, and drug history. And what are the drugs? Tenofovir, emtricitabine, dolutegravir. Everywhere emtricitabine is common. And now even lamivudine is also approved for PEP. So 2-drug non-PEP regimen do not result in excess seroconverters compared with 3-drug regimen. So whether you use 2 drugs or 3 drugs, results are almost similar. PEP may be an early ART and suppose you miss the bus, then it is very difficult to prevent at that time. And what is timing? Timing is very important. And how the 72 hours came, I will explain to you. The first dose, no delay. Within 2 hours, 4 hours, 8 hours, whenever you get. But definitely within 72 hours. It has to be taken up to 28 days daily. And if it is more than 72 hours, last dose, discontinue PEP. Because sometimes some doctors are prescribing PEP. नहीं कुछ फर्क नहीं पड़ता आप आए तो ले लो. But that doesn't work. So when that kind of person comes to us, we stop because there is no need of taking. Now, why it is there? Okay, so look at day 0. Day 0 is at the time of sex. Exposure of the HIV is only at the mucosal surface. Day 0 to 2, that is up to 48 hours, the virus gets collected by dendritic cells of your blood and brought to the lymph node. Day 4 to day 11, the HIV replicates in CD4 cells and releases in blood. And day 11 onwards, the virus spreads to almost all parts of the body. So here PEP will not work. After 4 days, PEP will not work. Day 3 is silent. We do not know what happens until day 3. Therefore, if the person comes up to 72 hours of exposure, we can still give benefit of doubt and provide PEP. But within 48 hours, it's the best to give PEP. Monitoring, you do HIV, 3rd generation assay at 6 weeks, 3 weeks, 3 months, and 6 months. 4th generation assay, 6 weeks and 3 months. Anti-HBsIg and HCV 3 months. Limited HTI testing at baseline for syphilis and urine routine, and at 2 weeks if you have STI symptoms, burning urination, post discharge, then, and at 3 months. But don't go for STD profile advocated by commercial labs, because they are saying STD profile, they are doing lot of antigen antibody test which they cannot interpret, you cannot interpret. You come to us, sir, HSV IgG positive. There has been a patient who flown all the way from USA and another patient from Dubai just because his IgG of HSV was positive. So they get misguided. That can be either a false positive or that can be a past infection. So in that kind of situation, if you just go to any lab, avoiding medical consultation, think that you saved money, you got wiser, you went on Google, searched some lab and went there. And they do your STD profile, charge thousands of rupees, and sometimes reports are all confusing. Chlamydia IgG positive, HSV IgG positive. They have no meaning. Then also monitor pregnancy, because if the exposure can cause you HIV, can also cause pregnancy. Ultra rapid vaccination for hepatitis B. This is the most unfortunate part in our country, that hepatitis B vaccination is at the pretense of the cost. And currently we are leading for one of the major pandemic because of hepatitis B. 3 to 5% of our population is hepatitis B positive, and that can cause you pulmonary hepatitis, that can cause pulmonary cancer, that can cause deaths. A number of VVIPs in India, one chief minister, one of the big person, they had hepatitis B, they died. Some of them go to the Singapore to get liver transplant done. But we do not advocate hepatitis B vaccination. Why? I don't know. Hepatitis B test is done almost at all places. You get admitted, triple H is done. Triple second H is hepatitis B. Pregnancy clinics, ANC clinics, ICTC, everywhere hepatitis B test is done. But if you are hepatitis B negative, you are not told to take vaccine. Currently, gladly, Government of India started hepatitis B vaccination free of charge under expanded program of immunization for children from 2011. But those who are born before that, or when the private practitioners did not start doing hepatitis B vaccination, people have not been vaccinated. So sooner the later, if you get vaccinated with 3 doses, at least 1 month gap between 2 doses, you are protected for whole life. If you are exposed without vaccination, take hepatitis B vaccination at 0, 7 day, 21 day, and 360 days. Reducing risk to exposure, escaping needles, most important, transferring a body fluid between containers, failing to dispose of used needle properly, poor healthcare waste management, non-occupational, which is safe practices, and PrEP. So you can go to for HIV testing to ICTC. There are more than 1,060 ICTC. You can come to us. You can go get a health test, home test done. Home test there are available. You go online, buy a kit, get the home test done, and then go to doctors. Adherence and risk reduction. So PEP adherence is very important. And we have seen from different studies, PEP adherence is very poor. And sometimes they get little nausea and they stop PEP, or they think, no, my partner is okay, there's no need. So what we need to do is look at all those issues, advise pregnant women, monitor renal function. If you're taking PrEP for longer time, at least 1 yearly, you should do your renal profile or at least serum creatinine. Counsel individuals which are for importance of daily dosing, and test individuals routinely for HIV and other STIs, but very limited STI test. What drugs? I already told you, but now even TDF, 3TC, and DTG, that is TLD, is okay. Recommended PEP, they are preferred regimen, they are alternate regimen. Preferred regimen, this is the Government of India's NACO's treatment guideline for PEP. So in adolescents and adults, TLD is good enough. Alternate regimen, tenofovir, lamivudine, lopinavir, or efavirenz also can be used, and there is one study. In children below 6, zidovudine and lamivudine. If hemoglobin is less than 9, then abacavir and lamivudine plus dolutegravir. Children above 6, zidovudine, lamivudine, lopinavir, ritonavir. If hemoglobin is less than 9, abacavir, lamivudine, and lopinavir. So the first dose should be given as soon as possible, but definitely within 72 hours. Care pathways of a PEP: assessment, counseling and support, prescription, and follow. All these four are integral part of the PEP program, and that should be properly done. The strength of private sector: we are non-judgmental, non-discriminatory approach, rapport and good communication, so that helps ensure adherence, long-term commitment, because we have been in HIV practice for 2 decades, 3 decades, 4 decades. Knowledge, specialized, abreast with current developments. We know what is happening currently globally, and adverse effects and management, and all drugs and different combo available in private sector. There are three type of different diseases, and there is management. This is HIV. It's very simple. If you come with HIV, we provide you treatment. You live a full life without any compromise in your length of life, quality of life, anything. But if you have HIV phobia, which is only fear of HIV, no real risk of HIV, that is more dangerous, and lots of consequences are there, including suicidal tendency. And that takes you to the obsessive compulsive disorder. There are more males than female. And if you talk about HIV phobia division of sex, it is almost 90% males and 10% female. Another disease called Google disease. People Google, and every gland, everything, any fever, any sneezing, they say, what are the reasons of sneezing? And they put a leading word, HIV. And that is seen. And suddenly they start thinking that they got the chance of getting worst of the possibility, rarest of the rare thing only in themselves. And then they suffer from this Google disease. And then they get exploited at the hands of people. And a lot of HIV phobia people are getting exploited. Sometimes by quacks, sometimes by our own qualified people. There's a one scoundrel in Delhi who provides PEP for 55,000 a month. And a lot of patients complain, but they don't want to go against that person, go to police and complain. So I think this kind of thing should be prevented by any ways of means. We should not be exploiting people on their emotions and the fear. Eventually bring bad name to our entire medical profession, and as it is, medical profession has no good name, and such kind of people will definitely bring more and more bad name. So take home message: a key population, especially MSM, continues to be marginalized. PrEP, PEP, and TASP should be integral part of the health education in our all conversation with the youth. Choose between safe sex, no sex, and PrEP. Once slip this chance, new ways of prevention are PrEP and PEP only. HIV phobia doesn't need to be treated with PEP. Just because somebody has got scared, don't treat with PEP. They just keep on counseling, keep on counseling. Sometimes you need to give them antidepressant, mood elevator drug. Regular monitoring of HIV and STI is crucial. If we need to get to zero transmission, PrEP and PEP accessibility is crucial, and public access should be provided for PEPC as well as PrEP. Key population: PrEP is effective when taken daily and consistently. It is not an alternative, but rather in addition to condoms. PrEP yet not approved in public healthcare, as I told you. So private remain only domain available. PrEP is inexpensive, but mindset is very expensive. We discussed with at one forum, and the government person said that as we know what is the HIV workload, we can calculate what is the expense required, but we don't know what is PrEP requirement, so we cannot even calculate and budget it. And this is as if you are at risk, take a risk, you come back, we'll provide you lifetime free ART treatment. But currently we cannot give you PrEP, which can prevent you from infection. So this attitude has to change. And the private sector should walk that 1 mile extra, network with at-risk population. When new things come, we tend to forget and discard the time-tested old things. Preventing HIV is holistic approach. One size doesn't fit all, doesn't work everywhere. Some people are averse to taking medicine, so non-drug PEP PrEP will work there. Vaccines are for adults too. HPV and hepatitis B vaccines are PrEP for those infections. We will have to wait for injectable PrEP. It is not yet marketed. So basically, there are two kind of practitioners in HIV field. Those which are with STD background, they will always say PrEP has to be used with condom. Those which are not with STD background, they may not talk about condom at all because they have not used the terminology and prevented STDs through condom. So they will say, okay, take PrEP. So we need to decide what is good for a person. So basically, we have all known the three monkeys, and the HIV has added the fourth monkey. And that fourth monkey is very important. And this is the extension of Gandhi's philosophy for the 21st century. Health should be for everyone. What Abraham Lincoln said, the best way to predict your future is to create it yourself. So more than half of the world is under 25. LGBTQI plus population is around 10%. More alphabets get added to the acronym and thus the percentage gets expanded. Age of establishing preventable health risk behavior is getting lowered and lowered. We have seen boys and girls of 15 or 16 or 17 getting HIV infection out of their own behavior. Developing healthy behavior now is more effective than trying to change the already established unhealthy behavior. Teach one to teach others. So this is a PrEP and PEP, and there are a lot of resources available. Only read authentic material, not only from Google. And the verdict is there is no one fit all in ARV regimen. So individualize all 4C: cap, cloth, chapel, and condom. All 4C, they need to be individualized. And U is equal to U is a great equation. Once you, now there is also T and D, target not detected. That means not a single virus per ml of blood after treatment. So I would like to thank the HETO team and the entire team for working on this thing. The idea of having a special session on PrEP and PEP. And I thank you all for your attention. I do not see how many of you were dozing or sleeping because it's an online session, but I hope some of my suggestions are helpful to you. If you are your doctor, then practice in this way. If you are a patient, if you are an individual, if you are a risk taker, then prevent any kind of infection which you can prevent by ideas I have given. And you are always welcome to touch base with us, and we'll try to answer your queries. Thank you.
Thank you very much, sir. This was indeed a wonderful, very informative and very enlightening session for all of us. And it gave us brief insights on the various preventive strategies along with the management and how to reduce the risk very much in detail. Thank you so much, sir, again. We would like to take some questions which we have received from the audience. So can I start with the questions?
Yeah, please, please.
Okay. So what we'll do is, sir, we'll take few questions on PrEP, then some questions if they are available on PEP, and then STIs. Okay. So starting with the first very question which we have received is, so there are some basic questions also like what is PrEP and how it needs to be taken and all, but that you have covered in your presentation. So I would like to take few questions which I feel that audience must be, they will be having interest in that. So what the question is PrEP safe, and does PrEP have any side effects which have been reported in patients?
The currently available drugs are very safe. When we say safe, means safer. And we have not seen any kind of adverse effect among those people who have been taking PrEP for many years. Now, we just need to monitor every year once at least serum creatinine. And if you are using TAF, then the chances of even renal harm, they are much less. If you are
Okay.
using tenofovir, then we need to also monitor bone and renal, both things. So I think that way, as I said, whenever you are taking any step extra, then it is a safer. It is not always safe. Only safe sex is no sex.
Correct.
And therefore, when you are taking any kind of risk and taking some precaution, I think that is better than getting a disease and taking the treatment for lifetime. Or take PrEP till you conceptualize in your mind who is your partner going to be for full life. Until that time, you use PrEP and then choose a partner and stay without PrEP.
Okay. Okay. So there is one more question, which is on who is not eligible for PrEP regimen?
No, no. If the person is allergic to any particular drug, like tenofovir, they cannot take. Those who do not want to take any medicine, they should not take. They should wait for a cabotegravir, a long-acting, being made available.
Yes.
But that will have its own. Like currently, the annual course of cabotegravir long-acting abroad is $22,000 a year, which is going
Okay.
to be marketed at much lower cost when it comes to India. But still, there are two steps. One first injection, then after 1 month, another injection. Then you can take every 2 months. So those who do not like medicine and injection both, then it is not for you. So then use only condom, and that is good enough for you.
Okay. Okay. So there's one question which we have received is whether TAF plus 3TC is better as compared to TDF plus 3TC.
Both are fine. Both are equal results. There is no difference between you take TAF or TDF with 3TC, with antihistamine. On 3TC also, there is no problem.
So efficacy
Obviously,
wise,
TC was
both
not
are
part of
similar.
it. DCJ has not yet approved. I don't know why it is stuck, but NACO programs allows 3TC. Actually,
Hmm.
3TC and FTC, they are exchangeable.
Exchangeable. Yes.
And most of the trials are done only on emtricitabine, and therefore they only talk emtricitabine. And in India, we hardly do any trial. So
Yes.
we need to bank on what is available from abroad.
Okay. Okay. So according to you, both are having similar efficacy. Okay. 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 There's one question on if one starts taking PrEP, does this mean that the person has to take it for the lifetime
No, no.
to prevent?
That means basically if your lifestyle is having sex indiscriminately everywhere with anyone without knowing the background, without knowing the person, there are fly-by-night operators where they do not even have any kind of contact with them. For example, you engage with sex through Tinder or Grindr, and next day you come with the problem. I ask that person, "Do you know the person?" "No, I don't know anything." "Do you have number?" "I don't know number. I don't know name. Nothing." So
Okay.
you are so much anonymous through this app that you don't need to know, you don't have to know, and you cannot know. So in that kind of situation, you should always take PrEP. But if you change your lifestyle, if you confine to one partner, if you stop having indiscriminate sex, you can stop PrEP. So it is not, if you depending on your lifestyle, you choose your lifestyle and then you add.
Okay. Okay. So can PrEP be used to help different couples to conceive? Like how it will be
See,
done?
for example, if there's a what do you call couple, one person is positive, one is negative, and they want to conceive, undetectable is untransmittable. So if the person becomes undetectable, particularly T and D, target not detected,
Hmm.
then the transmission is zero. But still, from the mental state point of view, we can provide treatment to the infected person and PrEP to the uninfected person.
Yes.
They conceive. And once they conceive, then there is no need. So that is possible. Or if they are in hurry, the person is not even undetectable, then the one person who is negative can take PrEP, and the person who is on who is infected can start a full course of treatment, and then they can conceive. So basically, we ask them to avoid conception till the person becomes undetectable. And with the current advent of treatment with the integrase inhibitor, they become undetectable within 6 weeks to 8 weeks. Usually we don't follow up them so quickly, but sometimes there is a situation where they need to travel abroad, they cannot come back, they have some decision to be taken, engage, marriage, pregnancy, everything. So they come within 6 weeks or 8 weeks, and we have found them becoming either undetectable or even target not detected.
Okay.
From
Okay.
crores of virus or lakhs of virus to become undetectable, it takes us 6 weeks to 8 weeks. So I think people can wait that much time.
Okay. 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 There's one question, sir, which mentions that what happens if you miss a dosage?
Very common question, and always this question comes. One is not always adherent in any practice, whether it's an exercise or taking tea or anything. It can be always time difference. So if you forget, and as soon as you remember, suppose You forget you're taking dose at the night, and you remember at mid of the night, take it. You remember early morning, take it. You remember after 12 hours, then take it. But you can avoid that next day's course, particularly that evening course, and then take next day. So there is no sacrosanct, there is no such rule. As soon as you remember, take it. If you miss, fine, nothing would happen, because there is always tail of the drug which is you are taking in your blood, and that will take care of the further next dose. They will keep on waiting for the next dose.
Correct. Okay. Okay. So we'd like to take few questions related to post-exposure prophylaxis now. So the question is, how well does PEP work, or how effective it is?
You see, if you have come within 48 hours, it will work almost nearly 100%.
Okay.
If the exposure is really to a HIV positive person or a suspected person, and you added a third drug, particularly dolutegravir or any third drug, then it is 100%. If it is up to 72 hours also, it is close to 100%. We cannot guarantee. It can be slipped in some people, because as I told you, third day we do not know. But after 72 hours, it doesn't work. So there is no point in taking PEP after 72 hours. So when people come after 72 hours, we tell them, wait for 3 months and we'll do your general test. Or you wait for 2 weeks, we'll do PCR. If PCR is negative, then you are negative for HIV. After 3 months, you do HIV, hepatitis B, hepatitis C, syphilis, and urine routine. Only these 4 or 5 tests are required. And till that time, Bhagwan ka naam lo.
Okay. Okay. Does PEP have any side effects?
There is no medicine, including water, which is without side effect. There will be other side
That's
effects.
true.
But current PEP, if we compare with the zidovudine, lamivudine, it was having so much nausea, so much vomiting, so much problems. People used to discontinue because of the side effects. Here with current PEP, I have not seen any single person discontinuing because of side effect. That means that adverse effects are not there. And this you are going to take only for a month. The people who are taking HIV treatment for 20 years, 30 years, 40 years, they're still surviving and reaching to their destination of 70, 71, 75 years of age. So there is no harm. So as I said, firstly, no sex outside. Firstly, no sex. Secondly, sex with only your close partner or one partner or spouse. If you are having, use protection. But if you have already taken a risk, then you need to take this additional risk also if there is some side effect. But there are no such side effect which will stop you from taking drug.
Okay. Okay. What if HIV is resistant to the PEP drugs? What can be done in such situation?
Currently, the dolutegravir drug which is used in PEP has a very, very low resistance profile. So in our practice with dolutegravir and also with bictegravir, we see now in 4 5 years, 6 years, hardly 1 to 2% people are registered, not even 1% or not even 2%. So in that situation, whenever you have that kind of doubt, always take a 3 drug PEP. And because all the trials are done with 2 or 3 drugs, they are not done with only dolutegravir. It could have been that only dolutegravir is good enough to prevent infection as a single drug, but those trials are not done. So I think you add such a drug which can prevent nearly 100%, despite having some kind of resistance in the other side.
Okay. Okay. There is one more question which is saying that can we stop PEP earlier than 28 days?
You see, there are people who would like to do self-experimentation, and we cannot have those kind of answers because sometimes, even we tell them you do the test after 90 days, they do on 76 days, 65 days, and then there's 60. There's no such protocol. So if there is no such protocol, the answer cannot be affirmative that if you don't want to take after 22 days, okay, you have taken whatever benefit you got derived is fine. Because the chances of transmission of even from one particular sex with the infected partner is 0.1 to 0.3 to 1%, whatever all STDs are there. So when the chances are low, then we cannot calculate how much is risk in you versus those who have not taken. It is just like a simple logic. If you are traveling ticketless, not that every time you will be caught, but every time you are traveling ticketless, there is a risk of getting caught. Then you said, मैं right से जाऊं तो पकड़ा जाने का chance कितना है, left से जाऊं तो कितना that you need to equate. But
True.
there are always chances, and therefore you need to be very particular. Don't do experimentation on yourself. Whatever studies are done, they are done by wise people. There are multiple studies, multi-centric trials on thousands of people. After that, they come to some conclusion of 28 days or 1 month. Do that, whatever has been told. Don't become your own scientist. A lot of people give me a lot of advice, and I tell them, please don't give me advice. You cannot get PhD by doing this in HIV. So don't experiment yourself.
Okay. There's one question, whether PEP can be taken if somebody is pregnant or breastfeeding.
Yes, it can be taken, no problem. Earlier, there used to be some dilemma, but now there's no problem. Even with efavirenz-based PEP, no problem.
Okay, okay. Yes, there is one question which says that can you take PEP every time if you have a potential exposure to HIV?
You see, PEP works only for that 1 month. And
Yes.
maybe immediate next day you had something, then your PEP has work as a PrEP. But if you are having dolutegravir can be in your body for a week after that. But beyond that, if you freshly exposed, you need to freshly take PEP. So every exposure after your 1 month period is over is a potential risk for infection. Therefore, you must take fresh PEP.
Correct.
Or if you are so much scared of that, then you can be on PrEP. There are people who come with exposure, take PEP, and would like to continue as a PrEP for longer time. Good enough.
Okay, okay. So there is one question which is remaining for PrEP, which is event-driven PrEP. So can you just throw some light on event-driven PrEP?
You see, event-driven PrEP are also good, but they are for those people who definitely can plan their sexual activity. There are some people who would like to have sex on a particular weekend. So they start 2 tablets 12 hours in advance, 1 tablet at the time of event, 1 tablet after 12 hours. So per activity, you need 4 tablets. And by taking 12 hours in advance, your the drug will be carried to the sites from where the virus can enter and already have that blockage mechanism. And at the time of event, you take one, and that will maintain a sustained flow there. And again, you are taking one more drug next day. That will so long as you are having a particular time limit, a fixed time, every week, every fortnight, every month, you can always take 4 tablets per sex. But if you are having more than twice a week, then 4 tablets per sex will become 8 tablets rather than 7 tablets daily.
Yes.
So you need to decide how you can time. And there are some people who cannot decide when to have sex. Sir, in a fluke of a moment, it happened. I went to the bar. For example, there are a lot of people who go to massage parlor. They probably know in 90% chances, 95% chances that they will indulge in sex. But still, they get dragged in it. I don't know क्या हुआ था मुझे मैं वहाँ करके आ गया. So in that kind of situation, you need to be prepped earlier or daily if it is not going to be planned.
Okay, okay. So there's one question which has come up on STDs. You have covered everything in detail. There is this question, basically how to manage STDs. If you can just summarize on how to manage STDs.
You see, there are 20 kind of STDs in addition to HIV. And
Yes.
every STD has a different manifestation. The manifestations are in 3 broad groups. Number 1 is ulcer. Ulcer is a jakham. Single or multiple, painful or painless, good looking or dirty looking. So some diseases are depending on that. There could be, for example, in syphilis. Syphilis is a single painless ulcer, like a punched out ulcer. But chancroid ulcers are painful with a dirty granulation tissue. So based on that, we decide whether it's a chancroid or a Donoris could be a larger ulcer, bleeding on touch, and that stays for much longer time. So that is donor anesthesia. So we decide what is ulcer. Secondly, it can be a discharge. A discharge can be white, yellow, green, or sticky, colorless. So there are four different type of discharge diseases. But most commonly we see are chlamydia and gonorrhea, and both can be treated with one injection of ceftriaxone. Then the third group can be growth. Growth can be cauliflower-like growth, which is a wart. Sometimes it can be skin tag. But usually coming on genital area, there's a wart, HPV. HPV can also cause you HPV cancer, anal, genital, or perianal cancer, oral cancers, oropharyngeal cancer. In female, cervical cancer, preventable through HPV and treatable through either cryosurgery or cautery, electrocautery. And there are multiple warts. One wonderful drug from homeopathy, which is called Puja 30, works very well. But it reduces, it doesn't completely finish. Then there can be a pearl-like growth, which is called molluscum. There can be a pimple-like growth called monkeypox, but monkeypox is very rare now. Then there are blisters coming on a burning skin, that is called herpes. And herpes has a range or what you call phases of suffering. Firstly will be burning skin, red color skin, then coming blisters with the water-filled lesion. Then the blisters will become mild, superior ulcer, superficial ulcer, and then scabbing. So that whole process of 8 to 10 days. So depending on that, we need to decide what is it. Some doctors are proficient in that. Some doctors will suspect and therefore some doctor will give this treatment, that treatment. There is something called quadriderm. When they don't understand skin lesion, then they give four drugs together. Is antifungal, antiseptic, antibiotic. So that way also people are treating. So basically understand, and all these diseases, 20, 4 we see in blood in HIV, hepatitis C, hepatitis B, and syphilis, and 16 on this side like ulcer, discharge, and growth. They come in 90 days. After 90 days, they don't come.
Okay.
So in 90 days, they come. And therefore, when person comes to you, you tell them that while taking a bath, just watch. You have got something. You've got something, then show. Otherwise, don't do test, nothing. At the end of 90 days of exposure, do syphilis test, do urine routine. If urine routine gives you person something, then you get into gonorrhea, chlamydia test. If you got within 2 to 3 days some discharge coming, that is gonorrhea and chlamydia, we need to distinguish between that. PCR can be done if you can afford, and treatment can be done in a single shot. And there are treatment like cotrimoxazole 10 tablets given, that also works. So there are different ways of treating STIs. But don't treat every suspected case even without knowing whether there is something or not. Only thing is required is post-exposure prophylaxis. When you patient comes to you, provide PEP for HIV, provide 2 tablets of doxycycline 100 milligram, that will prevent you from syphilis, gonorrhea, chlamydia, and providing hepatitis B vaccination at 0, 7 days, 21 days, and 1 year. So at least these are the PEP protectable diseases.
Okay. Thank you so much, sir. Thank you. So there is one more question that how recurrent STIs are seen. I mean, they are oftenly seen in patients with HIV, and is management becomes difficult.
See, sometimes recurrence is because of reinfection. Sometimes recurrence is because of inadequate treatment, and sometimes recurrence is because of the natural course of the infection. Now, natural course of the infection, recurrence is in herpes. So herpetic lesions will keep on every month, every 2 months, every 3 months. To reduce that, when the person comes with herpes, you treat with 2 things. Well, initially, if there's only red color, burning, tingling, then only ointment is required, acyclovir 5%, 5 times a day for 5 to 6 days. But when apart from that you see blister, then you require oral course also. The best oral course is valacyclovir, 500 milligram twice a day for 6 days. Acyclovir required to be given for 5 times a day or 4 times a day is difficult. Famciclovir 3 times a day, difficult. But now valacyclovir is one of the best drug available. By giving valacyclovir and also applying acyclovir 5 times a day for 5 days, you prevent the subsequent episode, which can be prevented, or the gap can be prolonged from 1 month to 2 months. If suffering was for 10 days, it can go to 8 days, 5 days, 4 days, 3 days, and within a year, 2 years, it will vanish. So the advantage of giving treatment is preventing suffering at that time, as well as preventing the course of the infection. When you talk about syphilis, then a lot of people are not neither penicillin, long-acting penicillin is easily available, nor people want to give the injection of long-acting penicillin. Then they try to treat with doxycycline and azithromycin, and that is inadequate treatment. The person will come back. And syphilis is such a silent disease where even if you are not treated, primary chancre will go into secondary syphilis after 1.5 years. And even if you don't treat at that time, it will go to cardiovascular syphilis and neurosyphilis after 25 years. And the person finally dies of those infections at that time. So you need to keep on monitoring and keep on properly treating. And the best treatment is long-acting penicillin, 3 doses, 2.4 mega units, divided in 2 buttocks.
Okay.
At 3 dose. 2 doses are enough if you cannot give third dose, but third dose is best one as a booster.
Okay. Sir, actually, we have covered most of the question. I would just request you, sir, to just summarize the entire session, just key messages, so that we'll get the overview of it.
Thank you very much again for having me on this program. I would like to tell people that these times are not so bad. You are so lucky. You have such wonderful drugs. You have such wonderful messages. If you have such wonderful knowledge across the world, and anything available from anywhere in the world is at a click of a mouse. But don't try to just Google, because in Google everything is not authentic. Everything is not from a proper source. The AI is very important, artificial intelligence, but take a proper knowledge. Secondly, if you are a patient, don't look at every symptom happening to you is because of your exposure, because you are in a country where there is a pollution, there is a cold, there is other infections going on, flu going on, RSV going on, sometimes COVID going on. So every symptom is not related to your exposure. Don't try to equate with that. Secondly, when you are having an exposure, you are also having kiss. So from kissing also you pick up some infection which are not sexually transmitted. So
Yes.
don't self-diagnose. Don't go and get randomly tests done at any labs, because those labs are interested in only money. They will do, you come for STD, okay, do STD profile, 7,500, 8,000, do it. They cannot interpret. Then you go around with the result, because even if you are perfectly healthy without any exposure, you go and get test done. Out of hundreds of the tests, 1 or 2 tests can go deviate here and there. And if you are hypochondriac, if you are scary personality, if you are OCD, then you get into problem for no reason. So don't get into that. Secondly, if you want to take PrEP, take daily. That event-based PrEP, yes, for some time it can work, but daily is better. In result-wise also, we have found best result in daily as opposed to event-based. In PEP, results are best come as early as possible. There are people who have taken risk in Thailand or somewhere and preponed their travel by 1 day and come immediately because they didn't want to show anything to there. So I think taking that kind of precaution, yes, okay, you end up spending unnecessarily, but don't get into panic. The panic is a worst disease. Phobia is a worst disease. Google is a worst disease. Get into proper knowledge, get properly treated, take complete course, and do not start in between. Do not experiment yourself. Do not Google and take medicine on your own. And there are people who would take you for a ride if you are scared. So be confident. Go to a proper expert and see that you are properly treated. And if you are not taken a risk, don't worry. If you just kiss somewhere, you touch somewhere, वो मेरे हाथ को ये नाखून निकला था, वो उंगली उधर चली गई. I seen a cotton which is red color. When drawing the blood, I didn't see she was using gloves or not. I didn't see whether somebody was using disposable syringe or not. So these are all hypothetical measures, hypothetical events. Don't bother yourself with this kind of thing and don't get into this trap. Thank you.
Thank you very much, sir. Thank you again. Since we are moving towards the end of the session, I would like to invite or request Mr. Vijay Thorat to give the last remarks. Yes, Vijay, please go ahead.
So it's such an exciting last more than 1.5 hours listening to sir. And we always get enlightened, which you have already mentioned, Hital. But I would really like to thank the audience to invest their more than 1 hour on this Sunday morning. But I'm sure they'll not be regretting while taking so much take-home messages. Most of the times, what we listen to the in the sessions is more of science, but the way sir puts up the science in a very simplified way, in beautiful cartoons which hits the brain at the right spot, and take home messages are very important. So many take home messages sir has already given. So I would like to thank the audience, definitely our IT team, Hitil, you, and none other less than Gilada sir, who had landed yesterday night, prepared his presentation, such an extensive, elaborative, exciting, and so much information. एंड टू डू लिस्ट सीधा सीधा सर ने क्लियरली बता दिया कि करना क्या होगा. ये सबसे इंपॉर्टेंट मैसेजेस है for the doctors and for the patient people with having risky behavioral pattern. And he was so open and blunt, and it's very important to be open and blunt. I've read a book of sir, a dedicated book written on sir too, and the 40 years of experience what he have done extensive work. He was never ashamed even to put the condoms in his neck and promote it, propagate it, when doctors were even fearing that patients of to take that HIV positive patients in their clinic. That's the time what sir has seen. And definitely, as mentioned, today's time is much better. 40 years back, there was nothing available. Now we have things available to prevent this dreaded infection, HIV. We have listened to Dr. Gilada sir on various pandemic. COVID, he was during the various pandemic, and definitely in COVID, he was so active, and he have shared so much of information during COVID too. And he never thinks twice for giving his date for such platform. Even after his such a busy schedule, he gave us time on this Sunday morning, and we really thank him from bottom of our heart to really to give your time and spread this piece of knowledge of more than 1 hour. Thank you so much, sir. Thank you, everybody. So we can call it this session comes to an end, and we are definitely going to release the recording of this video for the audience too. The audience can share with their peers and their friends, so that this knowledge, which has reached currently more than 350 people were live to share the figure which sir has asked, but this can reach to much more masses, so that they can be taking steps to prevent this HIV infection. Thank you once again, sir, and thank you entire team. We can close the
Thank you,
session.
everyone. Thank you so much, Dr.
Thank you.
Kilana.
Thank you.
Thank you, sir.